This is the recorded lecture for Medicine 1, and the topic is cough. Cough performs an essential protective function for the airways and lungs. It is a clue to the presence of respiratory disease, and it is an expected and commonly accepted manifestation of disease that causes patients to seek medical attention. It all starts with stimulation of receptors. Capsaicin, an example of a chemical that can stimulate the type 1 vanilloid receptors found in rapidly adapting receptors and C fibers. These are found in afferent nerve endings which innervate the pharynx, the larynx, the airways, even the terminal bronchioles, the lung parenchyma, external auditory meatus, and even the esophagus. Afferent impulses then travel through the vagus and laryngeal nerve and reach the cough center, found in the nucleus tractus solitarius of the brainstem. The cough reflex, mostly a series of involuntary actions, can be stimulated by cortical input as well. Efferent impulses coming from the cough center then travel through the parasympathetic and motor nerves, wherein the diaphragm, intercostal muscles, abdominal muscles are then stimulated to contract and produce cough. Cough starts with irritation of the afferent nerve fibers found throughout the airways. This is then followed by the inspiratory phase. The glottis opens on reflex with inhalation of air. Lengthening of the expiratory muscles occurs with the contraction of the diaphragm. Air fills the thoracic cage, generating positive flows and pressures. This is then followed by adduction of the vocal cords, leading to a transient upper airway occlusion. This is then accompanied by contraction of the expiratory muscles, generating introthoracic pressures as high as 300 mm mercury. This is then followed by the expulsive phase, wherein there is sudden release of laryngeal contraction and results into generation of a rapid flow. The kinetic energy released is usually enough to dislodge mucus and irritants from the insides of the airway walls. Irritation of the airways is followed by the three cough phases, the inspiratory, compressive, and expiratory phases. Irritation of the receptors stimulate inhalation and buildup of volume, while the compressive phase starts with the buildup of pressure against a closed glottis. The expiratory phase starts with the sudden opening of the glottis, generating rapid expiratory flow. This diagram demonstrates the changes in flow and pressure in the airways during the three cough phases. During the inspiratory phase, the subglottic pressure as well as the flow rate are both negative, allowing air to enter the thoracic cage. But once the glottis closes, there is no flow generated, but there is buildup of pressure, as seen here in the diagram. The sudden opening of the glottis generates a rapid expiratory flow in the expiratory phase. There are different causes of impaired cough, but basically it is due to impairment in one or more of the phases of cough. Tracheomalacia is one example of the causes of impaired cough. In a normal airway, shown in the diagram above, the tracheal support maintains the airways open during inspiration and during expiration. The collapse of the trachea during expiration is prevented by the tracheal support. However, with tracheomalacia, the abnormal configuration loses the support, which is shown here during inspiration and during expiration. This prevents the generation of flows which allow cough and effective cough. Cough strength can be measured by surrogate markers. A peak flow meter, as shown here, measures expiratory flow. The duration of cough gives you an idea of the possible cause. For those that occur with less than 3 weeks, it can be termed as acute cough, which may be caused by respiratory tract infections, aspiration, inhalation of noxious chemicals, and even smoke. Subacute cough, which lasts 3 to 8 weeks, may be due to tracheobronchitis and post-viral tussive syndrome, while cough lasting more than 8 weeks is termed as chronic cough, wherein it may be due to inflammatory, infectious, and neoplastic diseases. However, the World Health Organization defines chronic cough for areas with high prevalence of TB as cough with a duration of 2 to 3 weeks. So for countries that would have high prevalence of tuberculosis, the term chronic cough would be cough of more than 2 weeks in duration rather than more than 8 weeks in duration. In the 2016 update for the Diagnosis, Treatment, Prevention, and Control of Tuberculosis in Adult Filipinos, the clinical practice guidelines mention that a presumptive TB has any of the following: cough of at least 2 weeks in duration, unexplained cough of any duration in a close contact of known active TB disease, or chest X-ray findings suggestive of PTB with or without symptoms. Multiple studies mention the different common causes of cough, and it has been determined that the top 4 causes of cough would include cough variant asthma, gastroesophageal reflux disease, nasopharyngeal drainage, and medications including ACE inhibitors. This is a simplified algorithm for the evaluation of cough. So for a patient that would have cough of more than 3 weeks in duration, you have to check if the patient has ACE inhibitor treatment. So in this case, if a patient is taking an ACE inhibitor, the most logical course of action will be to stop the ACE inhibitor. So it is considered as a class effect, which is not dose-related, and it's found to be in 3 to 20% of patients. The pathogenesis of ACE inhibitor cough includes accumulation of bradykinin, which causes stimulation of C. afferent fibers in the airways, and the diagnosis is usually confirmed with the resolution of cough 1 to 4 weeks after discontinuation of the offending agent. Smoke inhalation stimulates the rapidly adapting receptors in C fibers, thereby causing cough. So in this case, smoking cessation will be warranted. Next will be evaluation for the common causes of cough, which includes postnasal drip syndrome, asthma, gastroesophageal reflux disease, wherein empiric treatment may be warranted. But if the cough persists despite the empiric treatment, a chest radiograph may be warranted, wherein the patient should be evaluated based on the nature of abnormality, or if it's normal or there's an unrelated abnormality, further evaluation would be needed. Associated symptoms may give you clues on the possible cause of cough, like shortness of breath and wheezing in asthma, and heartburn and regurgitation in gastroesophageal reflux disease. For postnasal drip syndrome, or what is known as upper airway cough syndrome, it can be caused by direct irritation or inflammation of the cough receptors in the upper airway. There are no pathognomonic findings in this case. Uncommon conditions causing chronic cough would include carcinoma, bronchitis, interstitial lung disease, cystic fibrosis, even psychogenic and habit may cause chronic cough. Cough can lead to different complications, including hypotension, arrhythmias, syncope, inguinal hernias, bladder inversion, incontinence, pneumothorax, and even rib fractures have been noted. Chronic idiopathic cough, also called cough hypersensitivity syndrome, characterized by dry cough or productive of scanty mucoid sputum, is diagnosed once serious underlying cardiopulmonary pathology has been excluded. In this case, an attempt at cough suppression would be appropriate. Narcotic cough suppressants, including codeine and hydrocodone, are thought to act on the cough center found in the brainstem. Side effects may include drowsiness and constipation, and may cause addictive dependence. Dextromethorphan, an over-the-counter centrally acting cough suppressant, has fewer side effects and less efficacy than other narcotic cough suppressants. It is thought to have a different site of action than narcotic cough suppressants and can be used in combination with them if necessary.